Appreciate it. And I'm also, there should be another one. We're also waiting for Damon Garso. Okay, so we'll hopefully he will join us so then he's able to speak. All right, so thank you again. Like I said, we do have quorum, so we could go ahead and proceed. Just a quick tidbits. If you are dialing in via telephone, Google Hangouts has muted you. So if you do need to speak to the group, press *6 on your phone to unmute and mute. If you are using your laptop for audio and visual during the meeting, you can control the mute function on the Hangout. And then we kindly ask only those who are speaking to the group unmute their devices, and then you can see that on the lower bottom of your Google meeting view, the mic button. And as for the DUR boards, you're more than welcome to reserve your questions till the end of the presentation, or you could put them in the group chat. Oh, perfect. We do have Damon Garzo present. And then public comment, if you do like to provide public comment for future-wise, the conflict of interest form must be submitted and have that on file prior to your speaking. And you can send that through Medicaid Pharmacy at utah.gov. All the attendees, there's a lot of people that we have that are phone numbers, and for record purposes, we have to also have who attended the meeting. So if you could send us a quick email of your name and then that you attended via telephonically, we would appreciate that. You can email us at medicaidpharmacy@utah.gov. The people in the group chat that do not have their name, you're more than welcome to just put your information in the chat function. Other than that, we really appreciate if you guys could give us feedback. This is our second virtual DUR meeting, so we always love to improve our process moving forward. So with that said, Catherine, it's all yours.
Okay, great. Thank you.
Thank you.
Good morning, everyone. All right, so from the agenda, can we get the agenda view? Great.
Here, I'll show the agenda that we have.
Perfect. All right, so meeting's called to order. And from there, we have welcome and introductions and review and approval of minutes. Do we have a motion to approve our minutes?
This is Eric. Move to approve.
I'll second. This is Michelle Hoffman.
Great, thank you, Eric and Michelle. All right, then we'll take a vote here. So all in favor of approving the minutes, say aye.
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 Any opposed? Abstentions? All right, the minutes stand approved. All right, next we have housekeeping items. Are there any housekeeping items?
Just a quick reminder, we do have two of the edits that went into effect last month. There was the gabapentin and pregabalin edits, and they became effective April 1st. We set maximum quantity limits there, and then we also prevented concurrent use. And then there was an 85 refill tolerance, an edit that also became effective beginning of April, and that was for controlled substances to move to 85% there. And I don't have anything else. Is there anything else that you would like to add, Jennifer?
No, you covered it. Thanks, Mel.
No problem. Thank you.
Oh, could you talk just for a minute about that? 85% tolerance on the.
Yeah, of course. Yeah, so opioids was, I believe it was 90. No, it was opioids was 100%, and the other controlled substances were at 80%. And so we wanted to align both of those, and we put them to 85%. So the opioids and then now the other control substances are both now aligned at 85% refill tolerance.
Okay, that makes sense. Thank you.
No problem. Thank you.
All right. So then the next item on the agenda is the P&T committee update from Brian Larson.
So our March meeting, which had been canceled, will be held next week. And we've got a number of things going on at this meeting. First of all, the representatives from the accountable care organizations will give their updates on their preferred drug lists. And then we will also be reviewing the cystic fibrosis gene therapies, the CAFTR drugs. And I think that'll be an exciting topic.
Indeed.
I'm
Thank
sorry.
you.
Could I just give one more update? I'm sorry, I'm going back in time, but I did want to mention too, as a housekeeping item to the DUR board, that in April we began an exciting outreach to promote hepatitis C adherence. So this is new for our team. It's a patient-focused intervention that identifies individuals when prior authorization is submitted to the pharmacy team. It's reviewed by the pharmacist, and when it's approved, an outreach call is made to the patient to provide sort of an NTM consult, so engagement and counseling about medicine, talking about side effects, and emphasizing adherence over that 8 to 12-week course. And with this, we develop and work with the patient to understand their barriers to adherence, and then transition over from the pharmacist for technician follow-up. So that follow-up can occur weekly, it can occur more often than that or less often than that, in order to promote treatment success and cure. And I think we mentioned this previously, but we use the PQA hepatitis C adherence measure, the quality measure, to evaluate our fee-for-service population. While we have a couple hundred patients who received therapy last year, we had a completion rate of about 75%, with the therapies that were prescribed and approved. And our goal is to get that up to above 90%, so that when a patient is prescribed their first round of therapy, they actually can achieve a cure. And with many of our single drug regimens today, and working alongside them, and also partnering with their primary care, their prescriber, we believe we can reach that goal. So that's a new outreach that was started in April. Thought I'd just touch on it today, and we'll give future updates as we have patients complete their 8-week course, and we're able to get some numbers around our success and some of our challenges too. We'll share those with the board.
Great. Thank you for adding that. All right. So are we ready for the next one, which is 9-month review, Spravato prior authorization review?
Yeah, let me just pull up the PowerPoint. We'll just do the entire screen too. Please let me know when you do see the PowerPoint.
Yep, I can see it.
Perfect. So today we'll be reviewing the Spravato as a 9-month review. So let's just dive right in. So we'll touch on the following points: the medication background, utilization, what other state Medicaid coverage criteria are, and then also lastly, our recommendations for the prior authorization form. For background, Spravato, or S-ketamine, is indicated for treatment-resistant depression when used in conjunction with an oral antidepressant. Spravato is administered intranasally and under the direct supervision of a healthcare provider. Dosing is divided into 2 phases. We have the induction phase and the maintenance phase, depicted by the table on the slide. As a patient progresses through the treatment course, frequency of the medication administration decreases. For the first 4 weeks, the medication is administered twice weekly, and then weeks 5 through 8, it's administered once weekly. For weeks 9 and beyond, the patient may continue to receive the medication once weekly or every other week. Just a quick tidbit. In clinical trials, dose could be titrated up to 84 milligrams at investors' discretion. And then in a short-term study, 67% of those patients actually received an 84 milligram twice weekly at day 28. And 61 of those continued to receive the 84 milligrams. So Spravato has a few box warnings, so they have 4. So the risk for sedation and dissociation after administration, which is why the medication requires patient monitoring for at least 2 hours for every administration. And then for potential for abuse and misuse. And then due to the first 2 bullet points mentioned, Spravato is only available through the Spravato REMS program. And lastly, we also see an increased risk for suicidal thoughts and behavior, which we see with antidepressants. So for requirements for the Spravato REMS program, they include the following: certification of a healthcare setting and pharmacy, and then also patient enrollment. So a little bit for the healthcare facility requirement includes designating an authorized representative to oversee the implementation and compliance with the REMS requirement. The authorized representative may be any of the following listed by the bullet point. And then additional provider administration criteria include, but not limited to, 1, medication counseling, direct supervision of patient administering the medication, patient monitoring for a minimum of 2 hours post-administration, and then also completion of the patient monitoring form that they're able to fill out following the administration. So just a quick dive into Medicaid Spravato utilization from the beginning of August 2019 through the end of April 2020. As you can see, there were 24 unique prior authorizations that were approved and 7 prior authorizations that were denied. When you take a closer look at the unique members that were denied, 5 of the PAs who were approved after resubmission, the requested information was obtained, and then 2 were truly denied. Based on Medicaid claims, we had 9 providers, 6 with mental health specialty, whether they have a certification or if their MPI is associated with some sort of psychiatry. And then also the area of the place that they were practicing, whether it's a facility that had a mental health facility relation to it. And then 3 were non-mental health specialty. On this slide, we have various states and their coverage, specifically surrounding provider type. So as you can see, Massachusetts, Texas, and West Virginia require a psychiatrist consult. And then while Ohio, Maryland, and Florida do not require the specific provider type. So moving on to the last slide. So I believe the original intention of this prior authorization was initially discussed was to allow a mental health specialist to prescribe this medication to address the possible access to care barrier to rural areas. So we would like to just to clarify, right now our current PA states that diagnosis of treatment-resistant depression is managed by or in consultation with a psychiatrist or a mental health professional. We would like to change the wording just to clarify to a mental health specialist. And so with that, I'm done with my presentation there.
Okay, great. So do we take public comment now?
May I ask a question?
Yes, yes.
Is the mental health specialist language, is this, has somebody requested this, or are we aligning with some new terminology that's emerging? I'm always trying to get my my words as specific as possible. So where are we getting this, if I might ask?
I know during our, I think it was Zolreso, where we had a mental health specialist, and that's what we had on our PA there. And so we were just trying to keep it consistent there. But I think it was just trying to align it there. And we also would like, once again, this was discussed prior to me joining with Medicaid. So I believe the intention was just to have someone in that a specialist in that field to prescribe this medication that was indicated for treatment-resistant depression.
So this doesn't.
Can I also?
I'm sorry. This doesn't imply anything for billing and coding. I mean, because medical in I come with maybe a little bit of preconceived idea of a specialist has a medical specialty. So we're not saying a specialist in a medical sense. You're talking about who's a mental health specialist by definition. Is there anywhere where that's defined for you in terms of who that would be? Do you have a reference for what professions that is?
That's a great question. I think what we're trying to look for is just any certification. When you look up the NPI right now, what we've been going off of, if we do see an NPI associated with any psychiatry association there, and then also we also look at the facility to see where they're practicing as well.
Does that, okay, I guess maybe let me ask a specific question. Does that imply a prescriber?
Mm-hmm.
No, right now we would like to look at both of those two fields. I feel like, well, Kurt, I believe, let me see if the other team would like to respond on that one.
I can step in here. So Dr. Weinstein, good question. So the challenge with the team has been what type of training is required of an individual who would prescribe this medicine. And initially, I believe when we looked at this, we had limited the use of this, or even like, so if we kind of look at the intent was to have some sort of mental health specified training, okay, when the DUR board initially looked at this. And the verbiage that was chosen didn't necessarily indicate that there was a specialty certification as far as psychiatry or someone, a mid-level who's trained and certified with a psychiatric specialty with their licensure. And the challenge came when we were receiving requests from individuals who may practice, and certainly they may have a family practice background, for example, and do a lot of psychiatric care that may not have that certification. And we brought this back to the board consideration. The REMS criteria does not require specialty certification. Our criteria leans towards requiring that. Okay, so with a specialty certification or training. And the question for the board is, we'd like your feedback on the language that is proposed. And also, now that we've had 9 months of experience, at least this drug's been available in the market, what is the board's recommendation around specialty requirements and understanding the population that this drug is meant to treat? Does that help answer your question?
Well, it does, and then I'm still not sure what we mean by a mental health specialist. So we've got a primary care person in the community who would need to consult with a psychiatrist or a social worker, right? A mental health specialist, in my view, might be a counselor in the community. So that's a very broad. I don't think that's what we mean. I'm thinking you mean a prescriber, somebody who has the specific expertise to advise about the prescribing of this drug, not, or do you mean somebody who's qualified in the management of depression, not in the prescribing of a drug that has a very specific indication, then that's a high-risk drug. So that's really my question, is what you mean by a mental health specialist in this context.
The original criteria was designed to limit the use of this drug to psychiatrists or prescribers who are trained mental health specialists.
Right.
Okay.
So, this language doesn't say that. It says the person needs to consult with a mental health specialist.
Or in consultation with, correct.
Yeah. So that's where I think we're going off the
Okay.
intent, and that's what I'm trying to point out. So I think I understood our original point, but now the language might be muddying that up a little bit, and that's really why I'm asking. And I see Dr. Siegfried, who's way more qualified in this than I am to weigh in. Thank you.
When I was posed this question just prior to this meeting, I gave a sort of a broad definition of mental health specialist because I also had concerns that mental health professional could imply a psychologist, a licensed social worker, someone who is not a prescriber. And I believe in someone in the definition that I provided that it would be someone who was predominantly, their predominant scope of practice was in diagnosis and treatment of neuropsychiatric disorders. And then I had in parentheses, including prescribing of medication, so that it sort of covered the type of individual that would be consulted, and it would not necessarily be a psychiatrist per se. It could be a neurologist, and I also said it could be a MD, DO, PA, or APRN. That was, but that was their predominant scope of practice.
So what I'm hearing from this is that we have that language, but there's a separate kind of like footnote of what that mental health specialist means.
Yeah. Could I interrupt quickly here? I'm sorry, the correct order. Could we have public comment, please? And let both of our representatives from the community speak. And then we can go into our board discussion so they can have, I'm sorry to interrupt the dialogue.
Sorry about that.
No, you're fine.
No, it's
I just
okay.
want to make sure that our representatives from the community have an opportunity to share their thoughts for their allocated time. And then let's dive into the discussion.
Yep, absolutely. Okay, great. So first one is, I believe, Charlie Ryan from Janssen Scientific Affairs. And does someone have a timer for public comment? Is that correct?
Yes.
Okay, great. Thank you.
No problem.
Are you on, Charlie Ryan?
Hi, good morning. Can you guys hear me now?
Yep.
Yes.
Yes.
Okay.
All right.
Okay. So again, my name is Charlie Ryan. I'm with Janssen Scientific Affairs Value and Evidence team. Just want to take a short amount of time to provide some thoughts around consideration of why it makes sense to allow prescribers with a valid DEA license to prescribe Spravato, obviously in addition to psychiatrists. A few things to consider would be the access that patients would have across the state to actually get in to see a psychiatrist, or the ability to consult with. It's another referral for patients to have to go through. If you look at it really from a prescriber standpoint, if they have experience treating patients with major depressive disorder, or specifically TRD here, and they're willing and want to go through the REMS certification process to be able to treat patients, then this is a very thought out decision. Not like just writing a script for benzo or opioid and the patient goes out the door. The REMS is quite extensive for prescribers, patients, and pharmacies. Likewise, based on the monitoring parameters required in the REMS, patients will need to be motivated as well. They're administered the drug, monitored for 2 hours, and then can't drive the remainder of the day. So this process, in my opinion, really self-selects those that truly need the therapy. Also, to add on the safety front around potential abuse, I would say the safe use of Spravato has been addressed in a few major ways. First of all, Spravato, as you know, is a C3 controlled substance by the DEA. So the regulations required of prescribers here are your safety layer number one. The second is how the drug is packaged or used. So to facilitate its safe use, Spravato is delivered through a single-use, disposable nasal spray that leaves minimal residual drug behind after administration, and is, again, as mentioned earlier, self-administered under direct healthcare professional supervision at the site of care. And the third is the REMS program that requires the patient, pharmacy, and healthcare setting or prescriber to be enrolled. Additionally, pharmacies must acknowledge a Know Your Customer form as well. This is another safeguard to ensure that the drug is shipped to an authorized entity, that being a healthcare setting or provider. Remember, the only time the patient actually touches the drug device is when they're handed it at the time of administration by the observing healthcare professional. Really, to summarize, prescribers who have experience treating major depressive disorder or treatment-resistant depression who have a DEA prescriptive authority must go through an extensive REMS process along with patients and pharmacies. And really, through this extensive process, the risk for diversion or abuse is significantly minimized, and meanwhile, suffering patients are still able to access care. Thank you.
Perfect.
Thank you. All right, our next public comment is from Ann
Hey,
Vincent.
could I have a question?
Oh, go
Dr.
ahead.
Smith, sorry. This is Joe, one of the pharmacists with the state. A question for Charlie from Janssen. I agree with you that access to mental health is a potential issue for our patients, and we certainly acknowledge that. You mentioned an extensive REMS. I and several of my colleagues have looked at the REMS program for providers anyway, and it looks like I don't see the extensive part with all due respect. It looks like all they have to do is fill out the form and be a prescriber, and they get approved for it. Maybe I'm missing something.
Yeah, sure. So I appreciate your point of view. There is a what is done kind of on the back end on our REMS process and how those prescribers are verified and ensured that they're able to prescribe. So from that standpoint, may seem like a simple step, but again, is another safety layer when you compare that to maybe other controlled substances. Sure.
So all they have to be is just a prescriber.
With a valid DEA license, and they will verify any sort of pertinent activity as it would relate to their board licensing with the medical board. I've been made aware that that's something that is checked on the Janssen side as well.
Okay. Again, it just seems like for any medicine, a prescriber has to have a license. Now, DEA, to control for prescribed controlled substances, it's an additional step to having that license, just like it is for us pharmacists. So, anyway, Thank you. It just
so I would say, if I could add just one more thing, is the prescriber is still the one that's going to have to enroll the patient as well. So they're still going to have to take those extra steps to actually enroll the patient in the process. So it's another ask of the prescriber.
And Charlie, just with all due respect, I just quibble with the term extensive REMS. We're familiar with lots of other REMS programs that are certainly more extensive. But thank you. Thank you for taking the time to visit with us.
Sure, fair enough. Thank you.
This is Dr. Weinstein. Can I just ask, while we're on the REMS, I personally have not registered a patient. I'm not prescribing this particular drug in this context, but I have been involved with REMS. Wrote the white paper with the NCCN on REMS years ago, and I have, as a prescriber, gone through some other REMS. So it just out of curiosity, one of the things that prescribers do on some of the other controlled substance REMS, there's an education piece. Not only are you signing the patient up, so does esketamine have a little education piece that the prescriber does when they go in to sign up the patient? Do you know?
I don't 100% know if that is a required step,
Okay.
but definitely can follow up with the board. My
Right.
gut is that is not part of the requirement now.
Can I
Right.
jump in? So I'm a prescriber for Spravato, and they do you do have to go through online training to prescribe it, and then they also train you in person, going over everything, how it's done, the requirements, things like that. So the Janssen does provide that and require it.
But before you sign up for the REMS, you have to have an in-person training?
Yeah, well, they did it with me over the phone. We went over everything. I talked to the clinical educator, and they went over all about the medication, made sure I understand the proper use of it, how it's given, the monitoring requirements, all of that. And that was after I did the online training. So they do definitely go through some formal training, yes.
Okay, I wouldn't know if that's required for the REMS, because
I believe it is. It was with me anyway.
Supplemental, right? Okay, thank you.
Yeah,
Thank you very much.
We didn't see that when we reviewed the form, so thank you, Ms. Vincent.
Sure.
Is that what you were going to share with us in your public comment, or do you have anything else to add?
Well, a lot of what I was going to say has already been addressed. We do need to specify what kind of mental health professional you mean. I run a small clinic for largely low income, lots of Medicaid patients. And I'm family practice, but my number one diagnosis is depression, anxiety. I counted last night, probably I see 120 patients a month with severe depression. And so getting these people treatment is a real problem. I mean, I treat depression constantly. In fact, United Healthcare has me listed as an expert in the field, but getting them approved for Spravato, I've been told that I'm not considered a mental health professional. So getting them a consult with a psychiatrist or someone else who is a huge problem. I mean, the waiting list is months out, and sometimes this is a real problem if people have self-mutilative behaviors, or they're suicidal, or they're, and I'm really wanting to get them help immediately. And I don't know how, there's a lot of confusion on what do we need to do to get them approved for Spravato. So clarifying the mental health professional thing would be a huge help. One of my patients who's, I only have one so far who's had a few treatments, excuse me, she tells me it's a miracle drug. So I'm seeing some real effectiveness. It's an amazing drug. Those were the big things, I guess I would say.
Okay, great. Any questions for Ann Vincent?
Sorry, yes, this is Dr. White. Sorry, get my technical things operational. It's Dr. Weinstein again. So when you interpreted in consultation with a psychiatrist or a mental health professional, in consultation with, you interpreted to mean the patient has to see a psychiatrist or another professional, not that you would consult.
That's what that's what I interpreted. But if that's not right,
okay,
I can change that. I can do something. I'll do whatever Medicaid wants me to do.
Okay,
to help me help these patients.
Just trying to understand where we are at the moment. Thank you.
Maybe for some clarification, typically when we have that language on a prior authorization form, what we're intending is that there's some kind of consultation with a specialist, and that could be provider to provider, peer-to-peer type of consultation. It doesn't necessarily have to be the member sees that specialist, because we do recognize that, especially for rural patients in underserved areas, it may be difficult for a patient to get in to see a specialist. But if there's, if a primary care provider is able to consult with a specialist, that can be very useful.
Well, what kind of documentation would you want if I myself consulted with a mental health professional on behalf of them?
Typically, what we see in those cases is chart notes attesting to spoke with this provider. This is what was discussed. Just some notes that address it.
And in my experience, if I've had other clinicians who've had a group of patients who have a similar condition, and they have one consulting expert in that area, they might set up a time to discuss it, that condition in general, present the and make it very efficient that way. It's one way of doing it.
And I had a quick question, because based on our discussion that went out of order, but with that language and the kind of definition that we were working with on that somebody whose majority of their caseload is treating mental health would potentially qualify under that definition, even if they hadn't had like specific psychiatry training during the course of their training program for licensure. Am I correct in that?
My intention was to include individuals predominantly who were neurologists. I would not say that a family practice doctor who, even though the majority of their practice may include comorbid depression, anxiety, and whatnot, would necessarily fall into the category of someone who would be treating, it's predominantly within their scope of practice, psychiatric disorders. I don't know, perhaps someone else can, phrase it better to kind of clarify that. But my concern is just that there is some, especially in the more rural areas, some type of ability for any, non-mental health, non-psychiatrist to review the case, ensure that this is the most appropriate treatment, that other treatments have been considered for treatment-resistant depression, and that we're also excluding other causes such as, overlooked bipolar disorder, general medical condition, side effects from medications, other causes that would be something that, would be necessary, to use this medication in a safe and appropriate manner.
Before we go into more discussion there, we still have one more public comment.
Yep.
Mr. Garza, are you available?
Yep, I sure am.
All right. You're more than welcome to start. Thank you.
No problem. Just to clarify, I have 3 minutes.
Yep.
All right. So
the people can ask questions, so you have more time. Thank you.
Absolutely. So my name is Damon Garza. I'm a psychiatric mental health nurse practitioner. I work at Weber Human Services, which is a community mental health clinic up in Weber County. our Spravato story is kind of interesting. Our primary person who is on the form and registered our healthcare organization with the REMS program is a family nurse practitioner. We currently, even though Ogden is a fairly urban area, we currently only employ one psychiatrist, and he only works 10 hours a week. And so I guess one of my big concerns hearing about this conversation was that potentially we would require a consultation with a psychiatrist specifically. Although after hearing more about this, I find that I would definitely qualify as one of those, potentially consulting providers. I know that right now we're treating 7 clients with Spravato, and to speak to some of the, I guess, comprehensiveness of the REMS program, I don't know how comprehensive it really is for providers specifically, but certainly the requirements from patients. A lot of our patients say that they feel very much ready to leave our facility after 30 minutes, and all of them are sticking it out for the full 2 hours. And I think that the fact that we're in control of the medication the entire time really creates a lot of safety for this product. We've not had any negative events since starting this. And we've had a few patients that have had very, just moderate improvements. And a couple of our patients don't look like the same patients at all anymore. They've really had some significant improvements. Interestingly enough, the one of our 7 patients that have been recommended by our psychiatrist is the one patient who looks like they may be failing treatment and looking to augment their depression treatment in some other way. And our family nurse practitioner probably has the best hit rate. And so I'm conflicted because I think that it's important for people to practice within their scope. And I also know sort of one of the foundational pieces of my own training was that at any point in time that I don't feel totally comfortable treating the patient, or feel like I'm remotely in over my head, that I should never worry alone and always consult with somebody. And so I don't know how much additional benefit, at least in our own setting, we would get out of requiring that, because it's just such a natural part of my practice. And it's my understanding that that's part of really any responsible provider's practice, is to consult when they feel that it's required. And I also understand that you guys have a responsibility to protect the clients that all of us are serving. So anyways, I just wanted to add my comments and say that, and also our psychiatrist consulted with me on his client. So it's definitely a back and forth response. Yeah, thank you.
All right, are there any questions?
Hi, this is Craig Hummel. I don't know if I have any questions, but I think I do have stuff to add to this. Some of our thinking is that, most depression is treated by non-psychiatrists and even non-certified nurse practitioners. The average patient is probably treated by a family practice doc. I have a couple of concerns with that, especially when it comes to treatment-resistant depression. If you look at the STAR-D program, and the STAR-D program included not only mental health prescribers, but it also included a large population of primary care providers. They only had about a 30 to 40% response rate with the first go-around. With the medication, and then I forget the number. If they go to the second level, they up that a few percent more, and then if they go down, they catch more and more patients who, I think it was go into remission, not to response. I could be wrong on that. In my experience, and this is anecdotal, but my experience with primary care physicians or primary care providers is they give the patient an antidepressant, usually an SSRI, and see them again in 3 months. That's really not the practice of a psychiatrist. I have a patient who's fairly depressed right now, and I put her on 3 antidepressants now, and I'm going to see her. I saw her this week. I'm going to see her next week. And if she doesn't respond, you know, I may go to Spravato. That I probably won't because she's bipolar depressed. But that was our concern in the first place, that someone with experience and not a primary care provider treat these patients before we go to Spravato. Now, if you look at, when I look at Spravato, you really use it in lieu of ECT. And I think you usually try more than a couple of antidepressants before you move to ECT. Now, Spravato is great because you don't have to get wired up and put under anesthesia and all of that stuff. But what we have done so far, I think we've taken into consideration the location, the availability of a mental health provider to do the Spravato, and have made exceptions with that. So, for instance, in one area, they have one psychiatrist. You can't get in to see them forever. And this was an APRN who is certified in mental health. Well, certainly, no, she wasn't. She wasn't certified in mental health, but she was the only mental health provider for one of the mental health authorities, and we did approve them. So it isn't as if we're you know, denying everybody. When they don't fit this profile, we investigate and make sure that we feel comfortable that they do have some mental health experience and that the patient meets the criteria. So I'll shut up.
Thank you for sharing that. Okay. Can we?
Could I ask a question of Mr. Garso?
Yes, please.
Just for clarification, Mr. Garso, you are a psychiatric nurse practitioner, correct?
Yes, I sure am.
And you've treated a number of patients with Spravato, correct?
Right now, I have only one client under my direct supervision, but I have some interaction with all 7 of our patients that come through the clinic.
So do you think a prescriber that's experienced in the diagnosis and treatment of neuropsychiatric disease should be involved in the administration of Spravato?
I feel a little bit conflicted. The conflict is between access and also safety. You know, knowing that it opens up beyond just psychiatrists, I think makes me feel a lot more comfortable. As you know, and I think all providers should have a pretty robust group of people that they can reach out to. It doesn't seem like an unnecessary hurdle to at least have a provider-to-provider chat about a patient and get a second set of eyes. So,
thank you.
Mm-hmm.
Great. Are we ready to look back at our criteria? Go ahead.
I just wanted to echo that I very much appreciate Mr. Garzo's comments, and that is exactly the type of interaction, especially in more rural areas, that I was hoping to foster, or I believe the original intent of the prior authorization was intent to foster, was not necessarily the intent was not that someone needed to actually be seen by a psychiatrist or by a mental health professional of any sort, but it had to be done in consultation with. It could be by phone consult or, you know, within, like Mr. Garzo's case, there's a psychiatrist within the clinic, which is not usual for most primary care, you know, facilities, but at least to safeguard safe and appropriate use, it could be, as I previously mentioned, it could be a psychiatrist or a PA or APRN whose specialty is mental health, where they can consider not just diagnosis, but also the different alternatives in terms of treating treatment-resistant depression, and which one would be the best choice for that individual patient?
Thanks, Dr. Siegfried. What I'm hearing then with that is essentially the intention is to foster almost a mental health integration type model for these complex, severe patients so that, you know, there is some connection and discussion with somebody with specialty training. And it does not have to be face-to-face with the patient. And there are multiple means by which this consult could occur. And I would also like to point out, because sometimes people are concerned about time and access and that sort of thing, but there are also billing codes for various provider to provider consultations as well. So if that was a concern in regards to barriers, there are provisions related to that.
I really appreciate this discussion, and I think it highlights our safety concern with this drug. And if we have the definition of mental health specialist, I'm to Dr. Siegfried's wording, with neuropsychiatric, because the drug does have the risks in that area. If that is somewhere that really spells out for a clinician like Ms. Vincent, who's handling these patients and has developed a certain area of expertise, but that wouldn't show up, you know, on record anywhere. But that could direct such practitioners to you know, the nature of the consultation, and the reason for it being, you know, these are the complex patients who have a certain safety risk, and all the various things, some of which Dr. Siegfried highlighted, what considerations need to be basically checked off. And any one of a number of professionals, specialists might be able to provide that consultation. As long as we have that language somewhere, I don't know, you know, mechanically where that gets described, but I think we've covered it, and I really appreciate the discussion. Thank you.
Is this a good time to go back to our wording?
Yes, this is a great time.
Absolutely.
Yeah. Let me just pull it up real quick.
I think too, if I can just comment as you're thinking about the wording, that the team is going to really rely on the words that are selected to determine who does and does not qualify as that prescriber, right? So as you're walking through that, just consider that that's really the gist of this discussion. So
have we ever put like examples next to the in consultation for clarification in other prior auths? Is that something we could consider?
I don't know if we have. Brian, can you speak to that?
Sorry, it took me a second to unmute. Yeah, we've had a number of prior authorizations that have had the language in consultation with. Hep C was a good example where we had a lot of non-gastroenterologists prescribing some of the Hep C drugs, and we had a number of specialists in the community that were very willing to provide those consultations with those non-specialists, and we would had a lot of success with that.
So on the wording for that one, does it say like what in consultation means? Like, is there a...
It just says prescribed by or in consultation with. is the
Okay.
language that's used.
Gotcha. So that's something we haven't really done before.
Now, looking at the wording here, changing the name from mental health professional to specialist makes a lot of sense. Just, if you look at the definition of specialist, it kind of aligns more to what we're after. Specialist is a person who concentrates primarily on a particular subject or activity, a person highly skilled in a specific and restricted field. So it kind of aligns more, the wording there aligns to more what we're looking for.
Yeah, it looks like Joe has a suggestion. Go ahead.
I'm sorry, that is what I was saying about the inference of the word specialist. Means you have a discrete competency in a particular field of patient care, essentially.
I do want to clarify for individuals, though, that it's not exclusive to having an MD or DO, that there are extremely competent PAs and APRNs that are actually, some of which I've dealt with, that are actually better than some of the, physicians that are psychiatrists. And so I don't, especially in rural areas where you find more APRNs and PAs as opposed to MD, DOs, just making sure that is, understood as well.
That was my concern with using the word specialist, that implies a medical specialty, and we would be restrictive of physicians, and that certainly has that implication. So we're trying to get around that. I agree.
Can we just spell that out in this wording?
Well, Joe has some suggested wording here. He wrote, an individual experienced in the diagnosis and treatment of neuropsychiatric disease and also a prescriber of mental health medications.
And that was almost verbatim of what I submitted prior to this meeting.
And I just amended to say just with prescribing authority, because that kind of gives the technical description of for Dr. Siegfried, right? But with prescribing authority, then would cover all those other non-medical specialists who have those scope of practice and credentials, who can prescribe, who would know these medications.
I definitely like that addition, because I didn't know how to add that in without adding additional verbiage that made it even more complicated.
Well, so Eric, oops. I unmute.
Well, and I was just going to ask, I mean, help me understand, what does experienced in treating mean? Because I think there's a lot of people in our community that write a lot of prescriptions for treatment, but I don't know that necessarily means they're experienced. I mean,
or qualified.
Yes. I think beyond just treating a lot of patients, you need to have some qualifications for that treatment. And I struggle a little bit because I don't know how to define those qualifications. I mean, but I think they need to be defined in some way.
Right. So if we say experienced, that just means somebody's doing it. Qualified means they have qualifications. Scope of practice means something else, right? So, how we choose that word, and experienced, I think, is not the right word. I agree with you. So we might say qualified, then that leaves somebody to say, okay, what's the qualification? That's a medical specialist. That's an NP with a psychiatric NP. That's somebody else who's got, some certification attached to their name. Then you would have somewhere else where the list of qualified mental health professionals that's a fairly long list, right? But qualification or I just went through this on another issue, so it's all swirling around in my head. But there are certifications, there are licenses, there's scope of practice, there's lots of ways we designate how somebody has the competencies and the recognized professional abilities. So professional has a broad implication, but if you want to put a word in here, you could say qualification, and then that would mean there's a recognition that that person has already met those professional whatever their discipline is, they've met those professional requirements. That's the word I'm looking for. And I'll shut up now.
No, thank you. I appreciate that. I think I like where you were going with qualified.
Mm-hmm. So Mo, can we get that wording on the slide for people to look at?
Yep.
Is that possible?
I think I just we could correct that. So
Perfect.
I like that. And I put neuropsychiatric disease because there are a lot more neurologists than there are psychiatrists.
Thank you.
Neurologists also deal more, can deal with and have training in psychiatry, although and vice versa. But that way we also, broaden the number of people that can be consulted.
Mm-hmm.
Or would feel comfortable being consulted, eventually.
Yep. So should we vote on this wording here, this part of it? Would that be appropriate?
I mean, if you wanted to keep the word professional in there, you could put professionally qualified, or you could just leave it like that.
would just to clarify this one, would a PCP qualify for this?
A primary care physician could have additional, have gone through additional training for a dual residency, but would not, a primary care physician. My concern with primary care physicians is sometimes they may not always, they have these patients and
here we have a
lot of obstacles to getting them in for treatment, and this seems like maybe, after trying 2 antidepressants and maybe not considering everything else, they think, oh well, this might be just an easy way to, treat my patient, than to consider, have at least a broader or a second set of eyes on the patient.
Perfect. Yeah, I think Joe actually did propose a little bit of language, which I did change up. I did add certified license, a scope of practice.
And it looked like we just had another suggestion of instead of also a prescriber of mental health medications, as just kind of shortening that up and with prescribing authority.
Yep. Changing that right. License
and you could even get rid of the "and" piece of that. So it would just be an individual qualified in the diagnosis and treatment of neuropsychiatric disease with prescribing authority.
Come on. There it is. Now, where did the font go? All words. Okay.
Perfect. All right, if we're getting pretty darn close here, can we get a motion?
Oh, sorry, I was on mute. Motion to accept changes with revisions specified.
I'll second that. This is Eric.
Okay, thank you. Any further discussion? Hearing none. All those in favor say aye.
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 Any opposed?
Aye.
Sorry. I need to give enough time there. Any opposed? Any abstentions? Okay, our wording passes.
So
All right.
knowing that we don't have much time to review the
Yes.
this, so we may recommend pushing that to next month.
Sure. That sounds good. Were we done with the in consult part of that as well?
Yes, that's all I had on that in consult part. But I believe there was another comment by.
Well, I was just asking because there was confusion about whether that meant the patient had to see the
Oh,
person
yes.
or whether it could be peer-to-peer.
No,
Did we
I
want to
would-
address that?
Yeah, no, I would assume that's peer-to-peer, and I think, you know, Dr. Weinstein and others kind of commented on that. So long as there's some documentation that there's been a discussion with another, you know, authority in the area, then I think that takes care of in consult with.
Yeah, I know. I'm just thinking of like from the interpretation of the people using this prior auth, if they, since our public commenters weren't completely clear on it from our wording, if there was something we could add to help them with that.
It looks like we had a comment in the chat suggesting consult means patient-specific prescriber to specialist communication to discuss treatment options.
Mm-hmm.
I mean, it certainly wouldn't exclude the patient seeing a psychiatrist. I mean, you know, not excluding a referral for a specialty consultation, but this is at the minimum, right?
Mm-hmm. All right, is this, can we get another motion on this part of it?
Do we want to somehow we don't want to exclude the patient being referred, so I don't know how to get that in there somehow.
Well, it's an or in the current language. So either managed by or
managed by. Oh, got it. Yeah, thank you. Okay, so moved.
I'll second that.
All right, there's motion on the table. It's been seconded. Is there any further discussion on the motion? Okay, hearing none. All those in favor of the consult language on the slide, say aye.
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 Thank you. Any opposed? Any abstentions? Perfect. All right, I think we're good with this one.
Sweet, thank you. That was quite a bit.
All right, so we're pushing
Yep.
Rebels is to next month. And is there anything else before we adjourn here?
No, not that I know of. We will see, well, you know, if we're able to continue having this virtually when we get more guidance there.
Mm-hmm.
But other than that, that is it. I'd just like to thank everyone. I really appreciate you guys' comments. Thank you guys for attending. It really means a lot to us.
And Mo, this is great doing it virtually. So,
yes.
So
I agree.
Keep it up.
We will continue virtually for probably the rest of the year.
Okay.
We love that. Thank you.
Yep. Thanks everyone for your attendance. Appreciate your contribution.
Thank you guys. If
All
anyone
right.
has feedback, you're more than welcome to stay on and I'll be available.
All right, is there a motion to adjourn the meeting?
Motion to adjourn.
Thank you.
Second.
All those in favor?
Aye.
Aye.
All right. Thank you. Motion's
Thank you, guys.
adjourned. All right. See you next month.
You guys, thank you again.
Thank
Stay
you.
safe.
Mhm.